Postoperative pain management for operation theaters to floors. 20 minutes, please. Kindly adjust 20 minutes.
Well, thank you very much, and thank you all for staying. My charge today was to look at some issues related to postoperative pain management. What's real, what's hype, and what's hope for the future. And please excuse me if I call something hype that you may believe otherwise. I don't mean to be offending anyone here, but it's what I was asked to do. This is not a how-to lecture. I'm going to look at three issues here. The pain assessment in children, especially very young children, the use of systemic and regional analgesics, and see from there what's doable and what's a hype. Starting with pain assessment, and if you can see here the different things that we can look at from the bottom up. If you look at number scaling, if you look at visual analog scales, you can see that this requires a more mature child, somebody who is at least of school age, 6 or 8 or 10 years of age. As you get to the much younger age group, you get to the toddlers, for example, the 2, 3, or 4 years of age, the younger patients, they don't really understand the concept of assessing their pain there, even if you give them tools that are designed for very young patients, especially if they are hungry. And that's often the case when they are recovering from anesthesia and surgery. It's also very difficult to distinguish between a child who is waking up in pain or waking up agitated or disoriented because the parents are not there. And we try very hard to have objective ways of assessing either pain or delirium, because this helps with the management and helps also with performing studies and so on. But you can see that if you look at the criteria that are available to us, they are very similar. Agitation and restlessness are all basically the same. Moving or having purposeful action, that's basically the same also. So what we find very, very useful, which is something that we do all the time there, is if we have any doubts, we give the child back to mom. And if the child calms down, then it probably was agitation or disorientation. If they are still complaining of discomfort or pulling up, then it's most likely pain that also requires more pain management. If the child is thirsty and you give them something to drink and they calm down, that probably also was not pain, was most likely because of agitation or lack of familiar environment. Although there was a recent paper here that showed that if you cannot bring the parents to be with the child and you give them something to drink, in this case here apple juice, that very often they calm down, and this will result in needing less opioids, which results in less vomiting there. Pain is more prevalent than we think, especially severe, moderate, and severe pain in children having major surgery. And if you look at this picture here of children who had moderate or severe pain lasting up to 3 or 4 days post-operatively, and how many of them had to stay in the hospital, the dark lines in these bars here, because of the failure of pain management. It is quite impressive. And unfortunately, surgeons underestimate post-operative pain, especially severe post-operative pain, and especially orthopedic surgeons. In this case here, they basically asked the surgeon what they thought of the child's pain, and they asked the nurses and the parents, and the difference was incredible. And because of that here, the Joint Commission in the US, which is the accreditation organization that allows hospitals to function and be paid by the government, came up about 17 years ago, exactly in the year 2000, and said that, rightfully so, pain is an issue that's not addressed very well in that country there. But they came up with recommendations that basically backfired eventually. They said that pain needs to be assessed more regularly and also managed more aggressively. And it came with the concept of pain being the fifth vital sign, that every time you see a child and you check their blood pressure and heart rate and so on, you should also have a number, an objective way of assessing pain. And if you don't do that, you don't get paid, and you get your name written up in the media and now on the internet, and everyone will know that you are a place that they should not send their patients to. So this resulted in many, especially orthopedic surgeons, I keep picking on them, prescribing more opioids in very generous doses for a very long period of time. And I'm dwelling on this because earlier this year I was in Bali speaking for the Indo-Anesthesia meeting, and they had oxycodone being introduced that particular day, actually. And the chairman there, Dr. Susilo, stood up and asked, what can you tell us? What advice you have to us now? Because we're going to be starting using these potent opioids in our patients. And these are the issues that we discussed, is that you have to be cognizant that you should not overprescribe opioids for trivial indications there. The premise of the Joint Commission was based on this particular paper here, which came about 27 years ago, that if you have pain and you give a child or an adult opioids, that the risk of addiction is very small. And if you can see, this is the whole paper, by the way. This is not an abstract. It's an 11 lines letter to the editor that was quoted almost 1,200 times without anyone going back to read what the real paper supposedly said there. And that's hype. That was based on very poor data. There was not an objective prospective study. The more recent data showed that, if you see in the highlighted yellow there, that actually the likelihood of a patient who is opioid naive, of giving opioids for pain relief after surgery, becoming dependent on opioid use, starts to become really significant about 4 or 5 days from the start of treatment. So one needs to be aware of that and limit the duration of administration, not if the child or the patient needs it, but don't just give, and you will think that's crazy, but this has happened. Somebody gets 300 tablets of oxycodone after having a toenail removed, for example. Again, some of the podiatric surgeons have done that. So one needs to be aware that the risk of addiction with acute pain, this is not the cancer patient or patients in chronic pain, but this is an acute pain patients. And as a result of this, you can see that at the year 2000, there was an incredible rise in the use of prescription opioids among high school students. The top part was because of medical reasons. They needed surgery, so they got the opioids. But the bottom part was because their parents had surgery, and the surgeons gave them doses of opioid that were way beyond what was needed for taking care of their pain medicine there. And Myron Yester looked at this issue here and looked at how many patients who are giving, these are adult patients, giving opioids, were told what to do with the leftovers when they no longer need them. And you can see here that those who were told to dispose, the red bars were much, much fewer than those who were not, and those who actually disposed of the leftover opioids were less than 4% of the patients. And guess what? If you don't throw them away and you put them in the medicine cabinet in the bathroom, your teenage children and their guests will come and will try them. They are safe. They are given by a physician, and you end up having addicted children there. So the number of deaths from opioid overprescription in the US here has gone significantly up since that time and became not only a medical issue, but a public relation and media issue there. So I hope this doesn't happen here, and that's why I'm dwelling on it a little bit, because it can be quite a serious problem. As a result of this, the Joint Commission now, the pendulum swung the other way around, and there is something called Prescription Drug Monitoring Program that anyone who writes postoperative opioids for pain management in children or adults must follow. And the sad thing is that in some states in the US now, the parents must sign a specific consent to allow their children to get an opioid dose after major surgery, and in some cases they restrict the number of days they can give the treatment to no more than 5 days, and then you have to renew it again. So hopefully sometime in the near future, the pendulum will come back in the middle and we'll have a more sane prescription opioids policies there. The other issue that relates to use of systemic analgesics is that the use of prodrugs for pain management is now known to be problematic because now the FDA, the Food and Drug Administration, had now a contraindication issued on the use of codeine and tramadol in children. And I'm not sure if codeine is available here in India or not. I know that tramadol is, and it's widely used, but now it used to be a warning, now it's a contraindication that codeine is contraindicated for children under 12, same with tramadol, and if they had TNA surgery, it's up to 18 years of age because of the risk of respiratory depression after they go home that can result in death. And the reason for this is that these drugs are prodrugs, so they get metabolized and converted into, in this case here, morphine, and that's how they work. The problem is that the top group is the normal patients who respond very well. The middle group, the poor, are those who do not convert codeine into morphine, and they get no benefit whatsoever from it. But the real risk is in the bottom group, the ultra-rapid metabolizers, who are going to have basically an overdose of morphine, and if that's given to them at home, it has been shown, and I think Dr. Cote has shown that very clearly, these patients can actually have respiratory and cardiac arrest at home there. This is more prevalent in African American and especially in African patients of Ethiopian origin. You can see almost 1 out of 3 patients is going to have that ultra-rapid metabolism. It's less of an issue in Asian patients, 1.5 or 2% of the patients, but that still is a fairly significant number when you add the possible number of prescriptions that can be written and the potential harm that can happen to these. The hope for the future is we know that for the last 10 years or so, that genomic profiling is available. It's something that, although it's not cheap, is something that may be available more freely in the future, and we can tell not only for opioids but also for other drugs how the patient is supposed to respond to these drugs and tailor our treatment to the genomic profile of the patient. As I indicated before, the issue is especially a problem for, at least in the US, most tonsillectomy patients go home the same day. And now they cannot have these opioids to take home. They have drugs like ibuprofen, and the concern was that you give them these drugs, they can start bleeding when they go home. This has been shown to be not true unless you combine ibuprofen with aspirin, for example. And there was a case report about that, which I know was a big hype, but it was a very specific situation that should not be taken to represent what happens to every patient. In here, I know you have diclofenac available. In some places in Canada, they have celecoxib. And I think in some of the places here, and in Australia, they do have also varicoxib that can be given intravenously as a COX-2 blocker, which will provide pain management and will not result in bleeding. Dexamethasone, of course, is very useful in not only preventing swelling, but also preventing pain. And for inpatients, patients who are not going to go home the same day, the use of dexmedetomidine will minimize the need for opioids and is a very useful drug for patients who are going to be staying in-house for at least 4 or 6 hours because of the longer effects of this drug. One issue about hype is peritonsillar infiltration, which used to be very commonly done when cold steel dissection was done because it did cut on the bleeding. Now with electrocautery and similar techniques, this is not a very useful block, and it does not really result in a lot of pain relief there. Using ketamine during opioid infusion, again, it's something that we thought, because it's what it's supposed to do, it prevents hyperalgesia and acute tolerance when you have opioid infusions for a long time. And we have been doing that for years and years until one of our younger faculty, Dr. Sophie Pasteur, did a study, a prospective study, and looked at patients who had the opioid infusions with ketamine and those without ketamine. And you can see here, absolutely, pain scores at rest on the left and morphine equivalent use on the right. There's absolutely no difference. So again, doing a study allowed us to be much more rational, and we no longer provide ketamine infusion for these patients. You saw a version of this picture before. Regional anesthesia has been around for at least 4,000 years in some form, in this case here in Egypt, for the pain management after circumcision. We don't do that. We do mostly kiddie caudal in these patients, and I'm sure most of you do. It's a quick block, it's a 60-second block, and in 95% of the patients, Again, that's my personal bias there. You do not need to do any more than feel the landmarks, give the injection, and it's done there. Do you need ultrasound guidance to do a normal routine caudal block? And I think my personal bias is that you do not, unless you have the 5% of the patients who either have abnormal anatomy of the sacrum that you can see on the left, or they have a big pad of fat on the sacrum that you cannot feel the landmarks. But for most other patients, unless you are trying to thread a catheter, for example, you really do not need to do that. However, one advantage of using ultrasound, if you choose to do it, is you can tell how far the solution is going in the cephalad direction. And if you do a high volume, if you give 1.5 ml per kilogram, for example, of bupivacaine or ropivacaine, you can see on the right side of the screen here that the level that you attain is going to depend very much on the age of the child. These are neonates, infants, and toddlers. For neonates, if your goal is to reach a T12 level, you have a 90% plus chance of achieving that. For toddlers, on the right side there, it's almost 1 in 5. So the idea of being able to get a high block from a caudal approach by just giving a high volume is really more of wishful thinking. It doesn't always happen. There's also one recent paper here which just came out showing that if you give this high volume compared to giving the lower volume of 0.5 or 1 ml per kilogram, you may be increasing your intracranial pressure. I'm going to call this hype for now because it's based on measuring the size of the optic nerve sheath. It's not direct measurement of ICP, and I'm not quite sure why that would happen there. We use caudal blocks extensively for hypospadia surgery, and the surgeons love it because it allows them to have the patient go home very comfortable, and we have been doing this for 40 years. We have surgeons who will not do the case if the parents decline the caudal block. Some surgeons came up, in some part, not our surgeons, saying that having a very comfortable child, having a blocked penis, may get the child to pull the catheter out because they feel no pain, they have no inhibition of doing that, and that can disturb the repair. I just fix the diaphragm, fix the catheter properly. This will not happen. And then more recently from Duke University, they had this paper that is retrospective that looked at surgical complications, mainly getting a fistula and so on, in patients who had a caudal block, the dark bars, and those who did not, the light bars. This is not a prospective study. This is an observation study, and they did not have caudals done for every child. There was no criteria explained which child got a caudal, which one did not. But their conclusion was that by doing a caudal for hypospadias, you increase the risk of having a fistula later on. And if anything is hype, I think this is hype for me. If you're doing caudals for outpatients, do you need to have them void before they get out of the hospital? And unless you are worried about their hydration status, that should not be a problem. And we have been doing, again, this for 40 years. We never had a child who had to come back because they had urinary retention after caudal anesthesia. Thoracic epidural, you heard a lot about it. It's a wonderful technique. We used to do that routinely for NOS procedure for pectus repair. We know that thoracic epidural is a very specialized block. You already heard about that. And not everyone, even in our own department, is allowed to do this unless they have an extensive experience and training to do it. And because of that, we no longer do thoracic epidural blocks for these patients. And I know even in Dr. Nas's own practice, that's not done anymore. We depend on PCA. If you like to do a paravertebral nerve catheters, that's also okay. And we can also have continuous chest wall infiltration of local anesthesia, which is very helpful in these patients. And speaking of local anesthesia, every time you cut the skin, every time you have an incision that gets repaired, we believe that there should be wound infiltration for postoperative pain management. The simplest, the easiest way to do this. So multimodal approach, less is more, and that's what we do now. I'm going to take the next 45 seconds here to express my view about using spinal for hernia repair in infants. And I know that you heard about the GAS study, and there are people now who are promoting the use of spinal anesthesia for hernia repair in infants. It has wonderful hemodynamic profile, but the problem here is that it does affect the respiratory mechanics in the baby. When you block the muscles of the chest, what's left is going to be the abdominal muscles becoming very hyperactive, as you can see on the right side here. The patient is breathing hard during the case and makes life very difficult for the surgeon. You end up having to sedate these patients, and if you do that, they will basically have the same profile for apnea as somebody who has general anesthesia. And also be very careful if you have an awake patient having a spinal to keep their hands out of the surgical field, because if you don't, sometimes the hand sticks in and ends up giving a hand to the surgeon during the case there. So these are the things that I thought were real, were hype, and hopefully in the future we'll have more designer anesthetics for these patients there. Thank you very much for your attention.